So we're welcoming today Kenneth Pinnow from Allegheny College. Ken is a graduate of Duke University, and he received his PhD from Columbia University. His first book, which came out with Cornell Press, was on the history of suicide in the 1920s mainly, which I still recommend, which I think is still a classic. He's been moving since then toward other aspects of medical history. More specifically, what he did earlier was partly medical history, but partly also sociology. Sasha, should I admit people, or you'll do that?
Sasha? I'll take care of, yeah, I'll take care of that. Right. Don't worry about that.
And he's been moving into other aspects of medical history. And I think Ken might begin with a little bit of an introduction to his larger project or projects that are going on right now. Sasha, if you expect me to talk, then let me know. Just send me a message, or if there's somewhere I'm supposed to be intervening. Okay.
Will do. Thanks, Johnny.
All right. So Ken.
Okay. Well, good afternoon, everybody. It's great to see such a nice mix of people. While we wish we could be physically together, I guess this is also one of the side benefits of us all being forced into Zoom and Zoom land, is that we can get together from all parts of the world like we are today. So I really appreciate everybody taking the time to join me here today. Before I get started, a couple of thanks. I want to thank Joshua Tucker and the Jordan Center for inviting me here, and also a word of thanks to the Center for having funded some of the research that is behind what I'm going to be talking about today. Also, I'd like to thank Sasha Spitalnik for all her work in organizing this and other events at the Jordan Center. There's always something going on, and so Sasha, thanks a lot. And of course, thank you, Yanni, for moderating today and being here. So as Yanni mentioned, what I'm going to be presenting today is part of a, I guess it's still new, although it seems like it keeps going, and it's been years since I started this, but I've been interested in the question of medical ethics in the Soviet Union, and this came out of a team taught course that I did here at Allegheny. I taught a course on medical ethics with a colleague of mine in the philosophy department, and we were exploring medical ethics from a philosophical / historical lens, thinking what these two disciplines could bring to the subject. And as part of this course, of course, I started reading a lot about medical ethics in Nazi Germany, the work that pointed out the fact that as horrific as Nazi medicine was, the Nazi doctors had ethics of a sort, right? They had notions of how they should conduct themselves. So that got me thinking then about medical ethics in authoritarian regimes in general, and more specifically, obviously, about the Soviet Union. Some work that has been done on medical ethics. Fran's with us, she's a great article, for example, about the medical secrets. But overall, there's still no kind of comprehensive history of medical ethics. And if I'm ever able to do it, one goal of mine is to maybe write a short book that just kind of explores the evolution of medical ethics over the course of the Soviet Union. But what I'm going to share with you today is work that focuses more on the earlier period. And I think what often happens, we get bogged down, we get started in the background trying to learn these problems, and then you start digging into more and more questions and issues, and I'm finding it hard to get out of the 1920s and 30s. So that's kind of still mainly where I am. But what I want to do today with you today is talk about the doctor-patient relationship and what I call the crisis of the doctor-patient relationship in the 20s and 30s. Based on a variety of published sources. These are primarily the medical press and also the general press, Pravda, Izvestia, for example. And while these sources don't allow us to equally look at the doctor-patient relationship, I'm going to try to talk today a bit about the doctor side of things and how they're viewing it. And one of the new things I'm going to try to get at today is speculating a little bit about the patient side of this relationship. But the key thing I'm going to, as I think about medical ethics, is that medical ethics is about power and the negotiation of power, how it's distributed between doctors and patients on one level, but more broadly within the formative years of the Soviet Union. So this is a lot about doctors trying to find their place in the new revolutionary order, and in some ways about how patients are doing this as well. What we're going to be seeing is that the doctors are going to, on some level, going to be trying to script the drama of the doctor-patient relationship through laws and regulations while they await this larger cultural revolution that's going to come about. But overall, notions of the doctor-patient relationship are also founded on assumptions about popular enlightenment, about the leveling of power, and also reciprocal obligations. So with that introduction, let's see, how come this is not going here? Okay, there we go. This is not moving. There we go. Okay, so here's what we're going to do today. I'm going to try to keep us at about 35 minutes or so that we have a lot of time for Q&A. And obviously, I'm going to probably raise questions that I won't get into. So feel free to ask me for more details or things in the Q&A. But I'm going to first start with a little bit of theoretical and historical context. Then I'm going to describe what I mean by the crisis of the doctor-patient relationship. I'll then move on a bit to the doctor's perspective of what's going on. And then, as I said, speculate a bit about the patient's perspectives, and then offer some very brief concluding thoughts about ways we might begin to interpret what is happening. Okay, so let's start with medical ethics, just very briefly. So as I mentioned, medical ethics can be read as an effort to regulate and channel the distribution of power between doctors and patients through the assignment of roles and expectations about the performance of these roles. Medical ethics is negotiated and it reflects culture, place, and time. The anthropologist Douglas Rogers more broadly considers ethics to be what he calls a field of power, where one actor or group attempts to impose its notions of proper persons or proper relationships on another. In terms of history, there's a small but growing body of historical literature about medical ethics, particularly if we look at the United States and Europe. These histories have ranged from what could be called traditional accounts, which have sought to ground contemporary medical ethics and bioethics in particular in the past. And then they range to these more critical accounts, which have looked at medical ethics as a kind of fig leaf. Basically, medical ethics were a way that medical professionals hid their attempt to monopolize power and to force out competitors. More recent literature provides a more complex picture. It emphasizes the multiple discourses of medical ethics and the importance of culture, economics, politics, and identities in its formulation and development. Albert Johnson, in his short history of medical ethics, argues that despite all the variety, there are three central elements or themes in all medical ethics. And these are the following that I have here on the screen. One is what he calls decorum, or the ideal character traits ascribed to the doctor. So these are often virtues. We would think about them as virtues. There's a deontology. Deontology is about rules and principles that tell us what we ought to do. It's very much about duty. And then the third is what he calls politic ethics, or the relationship between the community and the practice of medicine. So for today's conversation, I think it might be helpful to keep these three themes in mind, even though I don't explicitly get at them all the time. And indeed, the debates among Soviet doctors, which often took place in dialogue with other representatives from other professions and authorities, raised ideal questions about the ideal qualities of the Soviet physician, the doctor's rights and obligations, and their relationship both to patients and society as a whole. So again, medical ethics is about negotiation, it's about enforcement, and the institutionalization of norms and morality. So in terms of context, and I think many of you here probably don't need this, but I just want to offer some brief historical context, I think, to help us make sense also of what's happening. The historian Andreas Holger Mahle argues that debates about medical ethics and codes of ethics historically have been responses to change. So changes in prevailing economic, political, and social spheres. And that situation certainly describes the 1920s and 30s, given the Soviet regime's transformational projects. Doctors in the Soviet Union were part of a regime that is aspiring to create a system of universal health care for the population as part of its commitment to social welfare and redressing the wrongs of the past, especially towards certain groups of the population. And this, of course, begins very conservatively with the creation of the Commissariat of Health, or Narkomzdrav, in 1919, which attempts to centralize healthcare in the country. The other thing to emphasize, of course, is that they are pushing prevention, especially early on, rather than therapeutic care. This reflects the ideology of the organizers, but also the realities of low resources, right? It costs less money to prevent disease than it is to treat it. In terms of some features I'd like to highlight about Soviet medicine, although they are talking about universal healthcare, and this is something that Narkomzdrav is really pushing, that was in tension with class-based visions of healthcare. And in particular here, we have in mind the social insurance system, which has a lot of clout because of the money behind it. And they are pushing for a class-based vision of healthcare that argues that the working class in particular should be privileged in terms of the delivery of healthcare to the population. I'd also like to emphasize several dimensions of the physician that we need to keep in mind. First, doctors are now state employees. Private practice was never officially banned, but the state made it very hard for doctors to practice in private. And by one estimate, only 10% of healthcare was being offered through private practice around the early 1930s. Secondly, the doctor was seen as a social worker as part of that holistic approach to health that emphasized prevention. Doctors are expected to be active in their community, promoting health through the inspection of homes, the workplace, and through education. And then lastly, the doctor is a kind of gatekeeper at this time. Soviet workers needed medical certificates to avoid penalties for being late to work or for missing work. And doctors therefore became a critical part of labor discipline in the Soviet Union, and they found themselves situated between workers and their employers, which was the state. So in this context then, Soviet doctors are grappling with the formulation of an ethical system that recognized and facilitated these new roles and expectations. They're debating things like, should they have their own ethics? Like, can we even talk about medical ethics? Or should they have a set of ethics that is shared by all of society? Or then there's others who argue that need our regulations that spell out our duties and make transgressions pretty much a matter of law and social defense. So those are some of the general things. And as I mentioned, and we can come back to this, the doctors are talking about a lot of topics that are known to us today. There's debates about the medical secret, the ethics of private practice, euthanasia. Euthanasia was actually legal for a very short period in the early Soviet period. Abortion, the doctor's personality, and so forth. These are all various topics, although I'm not going to cover them in this talk today. Okay. All right, so that brings us to the crisis of the doctor-patient relationship. So what I'd like to state first of all is that I believe we shouldn't take the doctor-patient relationship as a given in the early Soviet period. And instead, what I'd like to argue is that it's becoming constructed as part of the new society, that the regime's trying to make it a normal and regular part of everyday life. This is happening in two ways. The first is by producing more doctors. So the Soviet regime is dedicated to educating, producing more doctors. And we also must, of course, recognize that more doctors doesn't mean better quality doctors. And that's kind of another underlying issue. So having more doctors out there is one way that they're trying to promote this kind of interaction. There's also, however, a cultural dimension to this, in that it relates to the regime's desire that its citizens adopt a particular attitude toward personal health and well-being. And basically by that, what we're getting at is that health is no longer an individual concern, but a matter of concern to the collective, to the rest of society. So the conscious Soviet citizen has this obligation to care for their body and mind, and to seek proper treatment when it's necessary. So essentially, as modern people, they're supposed to avoid the traditional or folk healer, the Baba, the Znachar, and so forth. And instead, they should be going to doctors and other representatives of scientific medicine. These could also be Felshers or physician's assistants. But the idea is that if you're sick or you have a question about health, you should be going to these types of individuals. So in other words, there's a kind of deeper cultural process that's going to be achieved over time. And here's where sanitary enlightenment comes in, the idea of trying to inculcate these values and this way of seeing things. So on the one hand, there's a lot of promise here. We're trying to kind of get doctors and patients to come together, but there's also some perils, because the more opportunities there are for interaction, the more opportunities there are for misunderstandings and conflict. And indeed, what we start to see in the late 1920s in public forums and journalistic articles and so forth are gatherings and debates about topics like the public dissatisfaction with doctors, medical mistakes, and the doctor and patient. And these are all expressions of doctors' anxieties about their status and treatment by patients. Some people in these debates are talking about what they call abnormal and unhealthy doctor-patient relationships, some of which had deadly consequences. They cited threats of violence, the beatings of doctors, and in some cases, threats of murder or outright murder of physicians throughout the country. By the mid-1920s, the word epidemic is being used to describe the situation. For example, in a 1926 review of Doctors' Rights and Obligations, Tede Epstein wrote that the country was experiencing, quote, an unprecedented epidemic of excesses against doctors, unquote. So a good example, or an infamous example of what's happening, was the 1927 murder of the physician Esterman. I don't know her first name or patronymic, and this took place in Kharkov. Esterman was murdered by a working class woman, a cleaning woman, whose son had died under Esterman's care. Apparently, Esterman had originally diagnosed the boy with malaria, but then after ordering some blood tests, she changed the diagnosis to paratyphoid. The boy died, and following the child's death, the mother accused Esterman of having misdiagnosed the boy in the first place, which meant that she called on a specialist too late. She took these complaints to the hospital administrators. I guess they didn't share her complaints. And as a result, she took matters into her own hands and killed Dr. Esterman. During her trial, the mother stated that one of her motives was to prevent Esterman from ever treating anybody else in the future. She was found guilty and sentenced to 5 years in prison. And while the court acknowledged that there were lots of problems in the medical system, many of these particularly affecting the working class, they argued that we shouldn't be solving these problems through the bullet of a gun. And more to the point, they concluded that Esterman never erred in the first place. So it was mistaken. So on the one hand, there's this specter of rough justice out there, alarming doctors, but there's also fears of legal prosecution. The other thing that's happening, there's reports about an alarming rise in legal cases against doctors for errors and negligence in carrying out their duties. These cases range from so-called intentional acts, like falsifying those medical certificates I talked about, or to performing abortions under unsanitary conditions, to less malicious blunders that could result from accidents or poor training, or the idiosyncrasies of medical practice. So the true numbers, even at that time, they were stating were unclear, but the data was suggestive to observers of growing tensions and distrust between doctors and the public. And here on my screen, these are some numbers I've taken from a few articles. I haven't gone through them yet to kind of see how this compares to the doctor-patient ratios at the time and so forth. But what I would emphasize is that the numbers were taken seriously and viewed with alarm, and they were a jumping off point for these conversations about the status of doctors and the jeopardy in legal ways that they were facing at the time. So if we look at what's going on here in terms of the doctors and the courts, the types of cases that we're seeing are doctors being either hauled to the courts or charged with misdiagnoses, questionable treatments, the death or injury of a patient. There's a heavy emphasis on the failure to respond to patients asking for medical attention. The house call is a big issue. People calling a doctor to the home and the doctor's not coming right away or at all, that's a big problem. The specialties most targeted from the data are surgery and obstetrics. In surgery, complications from the act of surgery, death from anesthesia, the infamous objects left in the body, a sponge, things like that. In terms of obstetrics, many of the cases are abortion related because even though abortion has been legalized, there's a criminal, in the criminal code, Article 140 places a lot of limits in terms of how it's done and where it's done. And some doctors are being hauled in front of the courts because of violations here. The other thing that's going on here is that doctors are concerned because of the way law is being used and the way law views medical practice, right? In some cases, the law does address specific realms of medical practice. I mentioned there's a specific code about abortion. There's a code about requirements to provide medical assistance. And of course, because the state is licensing doctors, there's statutes in there about who is and is not allowed to practice as a physician. In other cases, they are using codes from the criminal code or articles from the criminal code that deal with the health and life of individuals. So a doctor could be charged with murder or manslaughter or bodily harm, depending on what has happened. And then also very interesting, reflecting the fact that doctors are seen as employees of the state, they charge them with codes reflecting general professional duties, abuse of power, dereliction of duty, and so forth. Now, what doctors, how they read this, and I'm not going to go through this, we can come back. What I've done here is put together some nations that are commonly put forth in these debates about why this is happening at this particular time, and then some of the prescriptions to this. So I just to emphasize a few things. There's a common perception that the public is just more aware of its own power. They have greater faith in the courts. They have a stronger legal consciousness, so that's why they're turning to the courts more often. But they often emphasize that a lot of it has to do with the lack of knowledge and understanding of medicine. That ironically, people overestimate the power of medicine. That they go into the exchange with their doctor with a very heightened sense of the doctor's power, and then when things don't go as expected, this leads to disappointment, anger, and so forth. The doctors will also emphasize the limits of the Soviet system at the time that interferes. And as you'll see, then they will propose solutions that respond to this. What I'd like to emphasize before moving on is that some of these solutions are short-term or of the shorter-term variety. Others are longer-term, right? That we're getting back to this question of cultural enlightenment, the inculcation of values and norms, and that's going to take time. So this is one of the tensions in terms of altering people's behaviors and perceptions over time. And then what do you do in the interim, right? What are some other ways to shape that? So in the end then, what we get here is that there's a broad debate about, you'll see this title in a lot of, for forums and articles, pamphlets, doctors' rights and obligations. So a lot of debates about what are our rights, what are our obligations. And this is in response to a lot of ways the vagaries of medicine and concerns about what are called vrachebные ошибки, right? Or medical errors, medical mistakes, because the law doesn't really address these, right? As I mentioned, there's codes in the law that can be used, but they don't really specifically get at the question of a medical error. What is that? Is it intentional, unintentional, and so forth? So one of the things that doctors push for and eventually did get is the creation of medical commissions run by forensic medical experts. The idea being here that only doctors could really understand other doctors and what they're going through and judge them in terms of, did they diagnose correctly or not? And the idea then would be that these medical commissions would do a kind of preliminary check on any accusation before it went further into the court system. And what's interesting is that doctors really had to kind of push back here, or push against the perception that they were asking for special treatment, that the doctor somehow was not subject to the law in the way that other Soviet citizens were or not. So this is something that they had to navigate. So on the one hand, they do push and in some ways get themselves inserted into the process, which we could view as maybe an expression of if not autonomy, but professional power being recognized, right? Expertise. But more broadly, what you see happening is a heavy emphasis on regulation. That doctors are clamoring for, in essence, protection through the law, right? They're asking for more law or more regulation. The idea being more rules equal more clarity, equals fewer what they call collisions between doctors and patients. So in a way, I think it's kind of a pragmatic response, and it's kind of exchanging some power for protection from the state. And Fran, you can correct me here, but I think if I remember your article correctly, one of the things you found in the medical secret was the willingness of Soviet doctors to give up some power to other authorities, and that kind of was something that really stood out there. So they're asking for the construction of a legal code or regulation that will provide clarity, set boundaries, and so forth. So I want to give you some examples here of what they're talking about. So a lot of what they're asking for are, in essence, rules and regulations that tell people and doctor, but also here others, what can and cannot be expected of doctors. And also, if you cross those boundaries, in some cases, there might be greater costs. So for example, in 1926, there issued regulations that were precisely the kinds of first aid that a doctor was supposed to provide during accidents and emergencies. And this was said to potentially protect doctors from legal prosecution. More importantly, Narkomstrov issued a series of circulars that aimed to establish clearer boundaries for doctors' day-to-day activities and their interactions with patients. According to one survey of the medical legislation, the lack of any standards regarding receiving hours or house calls resulted in those collisions I talked about, and also nerve-wracking conditions for the doctors. And indeed, the medical press has all these stories about patients who are angry because the doctors made them wait, right, in line before they were seen, or failed to come to their house at any time of the day. So to remedy the situation, they come up with regulations that would, for example, allow physicians to set their reception hours, although they had to consult with local authorities. It allowed doctors to be off duty on holidays. And it also allowed them to reject house calls for cases that merited a clinic visit or hospitalization. And they also worked with the Commissariat of Justice to punish abusive behavior among patients. Verbal and physical offenses against doctors could now be prosecuted as an attack on a state worker during the execution of one's official duties. So here it's kind of interesting. The medical community is using the regime's rhetoric of labor rights and the doctor's status as an employee of the state to its advantage. Now, very briefly, what I see also going on here, and there's a debate about what's the best way to discipline people, right? And this could be either doctors or patients, external pressures or external modes or internalization of norms and so forth. And I think this is some of the tensions here. Because what's interesting, there are some doctors in the Soviet period who argue that we don't need laws and so forth, but what we should rely on is the doctor's conscience, that the doctor is ultimately the last court, right? They even use in one case the word samasud to talk to the doctor's conscience, literally judging oneself. There's all this stuff in there about how doctors take what they do very seriously, and they essentially allow the individual to follow their own moral compass. That's rejected by most commentators for the Soviet period because they argue that it's arbitrary. It would recognize, again, doctors as this kind of special caste or group in society. And finally, that doctors don't work for themselves anymore. They work for others. As one doctor wrote, quote, "Every doctor is a little screw in that big, complex machine, which has as its goals the state's protection of the people's health." So what they start talking about then is that we can't rely on our own conscience, although we can come back to this. I do think that they are trying to inculcate certain norms and values, but they also talked about the fact that there's a new judge out there, right? And that medical ethics in a narrow sense is being supplanted by the public, or as one doctor said, it's being supplanted by the court of the people, right? So the people have a role in keeping doctors on their toes. So that brings me then to the question of the patient. How did patients perceive their encounters with doctors? Did these encounters, or did patients in some ways express their own notion of ethics, of right and wrong and so forth? And here I've been reading a lot of the current anthropological work on the post-Soviet medical world, and I'm jealous of these individuals. They're able to go in there and do interviews. And I'd highlight, for example, the work of people like Michelle Rifkin-Fish and Anna Tyomkina. And basically, what they reveal is the importance of looking at the patient side of the doctor-patient relationship, and also recognizing the fact that the doctor-patient relationship is mutually constituted, right? That it's part of a mutual relationship. And they also re-emphasize the fact that norms and practices that appear one way to outsiders mean something very different to insiders, right? And most famously, they do some really good work on unofficial payments in the post-Soviet medical world, where the corruption inside is actually seen as an ethical way to achieve good care and to recognize doctors' authority. Historians of medical malpractice also point out that the patient perspective is important for understanding what is happening because culture and context really matter to understanding, for example, why medical malpractice became more and more prevalent over the course of the 19th century in the US and then eventually in Canada. And what they argue is that the increase in medical malpractice was not simply the product of developments and advancements in medical techniques, but it was about changes in culture, the way that people saw their body and understood their lives. So for example, as societies secularize, individuals may be more willing to place responsibility for misfortune on a person, right, rather than on some sort of higher being. They also have maybe different notions of productivity and so forth, which could be also affecting them. So what I'm getting at here is the value of looking at the patient perspective. But the problem, of course, that I come up with is how to get at that, right? I'm relying on published sources that primarily reflect the doctor's perspectives or other people's perspectives. But I think that with some careful interpretation, we can come up with some, I guess, broad observations. And what I want to do just in a few minutes here is talk about what I see happening from the patient perspective in terms of where their dissatisfaction is coming from. The first is, I think there's signs, obviously, that patients are dissatisfied or have certain expectations about doctors in their therapeutic role, right? So there's all sorts of expressions of dissatisfaction in terms of the encounter with the doctor. Parents are lodging complaints about doctors performing perfunctory exams on their kids. Patients are lamenting that the doctor only spent a few minutes with them. And indeed, one of the persistent images of medical care throughout the Soviet period was its factory-like quality. Even in the 1920s, you see doctors lamenting the fact that their demands, the demands on their time, meant that they could spend no more than 10 minutes per patient. And indeed, they often had quotas. They had to see a certain number of doctors per day, which meant so many per hour. So such brief exams, in some cases, were cited as the cause of medical errors, right? They could lead to incorrect diagnoses, which then could lead to incorrect treatments, or maybe the failure to properly explain the treatment. But I would also suggest that they're equally important for what they signal to patients about the doctor's attitude, right? A common refrain among dissatisfied patients was that doctors were indifferent to their stories and their suffering. And viewed in these terms, medical malpractice cases gave patients maybe some sense of agency. This is speculative, right? But they were a means to address the humiliation of feeling overlooked, tossed aside, and de-individualized. I also see signs that patients are dissatisfied with doctors in their roles as state agents, right? Or state workers. There are examples in terms of both violence, but also medical malpractice of people expressing dissatisfaction with doctors in their role as gatekeepers in the social insurance system, right? And in terms of their role in trying to enforce labor discipline. So we have incidents, for example, of violence committed by patients who are angry with how doctors treated the request for a medical certificate. There's one case where a patient physically assaulted a doctor after refusing to let him skip the line for that certificate. And there's also threats of people using violence to get that certificate approved, right, and signed. So one way I see this is that the dissatisfaction with doctors' role as gatekeepers raised questions, I think, maybe in patients' minds about the primary loyalty of the doctor. Patients, in this sense, were judging doctors in the role as state agents and employees, with the implication being that the doctors were placing the interests of the state or the factory employer or enterprise over the interests of the patient. And indeed, if you look at Mark Field's book about the doctor-patient relationship that he wrote in 1957, there's a whole chapter devoted to in a way, the deformation of the doctor-patient relationship that came out of the medical certificate process, right? Because I think in some ways what it's getting at is that patients are beginning in some cases to see the doctor as somebody you have to get through. Doctors in turn begin to have to question their doctor's motives, why their patient's motives, why are they there? And it's getting raising questions then about trust, the lack of trust on both sides. The third area of dissatisfaction then is with doctors as class enemies. And indeed, social class was a very strong structuring element to to patient complaints about their doctors and to the violence, because social class is very much shaping the expectations that patients were bringing to their doctor. Soviet workers in particular entered into that relationship with a message that they've been receiving that they should be given preferential treatment, right? And that they have rights to make demands on doctors. And indeed, many of the conflicts appear to have originated in the tensions between these expectations and reality. So for example, what a doctor might have seen as an example, as a product of the healthcare system's limitations, meaning the demands on their time, those perfunctory things, a patient might have interpreted as, in class terms, as a doctor violating the regime's promises. So the doctor becomes then, in this case, as an obstacle, right? Someone motivated by a different set of values and priorities. And indeed, the regime is contributing to this mistrust because it's sending out contradictory messages about doctors throughout the 20s. On the one hand, they're being lionized as these heroic individuals going out there to help improve the health of the nation. But on the other hand, they're also having their class loyalties and backgrounds called into question, particularly in the late 20s. And in terms of doctors, this comes to a head or has its apotheosis in some ways in a series of show trials that take place. These show trials promote the idea of the doctor murderer, right, who's out there, which is going to create fear among the public. The first trial took place in 1930 against a group of doctors in Kharkov. They were accused of involvement in a conspiracy to restore capitalism and promote Ukrainian independence. And more specifically, they were charged with medical terror, plotting to kill communists by poisoning them through the use of bacteriological agents. This is repeated in 1938 as part of the wider campaign against the right opposition amid Stalin's Great Terror. Most importantly for our discussion, in both trials, the prosecutors brought up what they called so-called medical ethics to pillory the defendants for violating their duties and using ethics as a mask. So the doctors, in other words, had violated their vow to help the patient and instead used the trust given to them to contemplate murder and to do things against the state. And this suggests the ultimate betrayal of a doctor, right? So to summarize this brief section on the patient then, I think that expressions of patient dissatisfaction are suggestive of the expectations that they brought to that relationship. There's signs that many patients were looking for doctors to live up to an idealized image associated with medical ethics. They wanted to be attended by caring and humane practitioners. However, others had desired a more transactional relationship, given the doctor's role as a gatekeeper. They simply wanted a medical certificate to be signed and approved. Both sets of expectations could produce conflicts. Both found reflection in the rhetoric and actions of patients who channeled their dissatisfaction and disappointment through both legal and illegal means. So to pull this all together, I want to just provide a brief set of conclusions, and then we can open it up to the Q&A. But I want to start by saying that I think one way we can read the crisis of the doctor-patient relationship is as the product of tensions resulting from the claims that doctors, patients, and state, which is the broader actor here, were making on themselves and each other. For example, while doctors sought to minimize conflicts through laws and regulations, they also had longer-term expectations of patients that emphasize the development and internalization of certain norms and practices. The ideal patients of the future were to have more reasonable expectations of medicine and also to know how to use their newfound knowledge and power in responsible ways. Patients, in turn, were expressing a desire for their doctors to be attentive and caring, to be responsive to their broad needs, and to treat them with a dignity congruent with their social and political status. The Soviet state, for its part, was placing obligations on doctors and patients, along with granting rights and benefits. So to me, the various claims suggest that the construction of the doctor-patient relationship and the expected roles within there were also about carrying out one's roles as Soviet citizens. So it's related to concepts of Soviet citizenship. And finally, I think that we can see the tensions between doctors and patients as a result of two paradoxes here. First, the first paradox is that historians of medicine, medical malpractice in the US and Canada, highlight the fact that there is a paradox of medical professionalism. Advancements in medical techniques and treatments particularly at the turn of the 19th and 20th century, raised the prestige of doctors, but also raised expectations and exposed them to lawsuits. And this appears to have been partly the case in the Soviet Union as well. As I've mentioned, one of the most consistent explanations for the increase in legal cases and so forth was a public overestimation of the power of medicine and a failure to understand its vagaries and limitations. The second paradox, I think, has to do with the process of acculturation. So the interpretation that this was coming out of, in a sense, popular ignorance, obviously emphasizes the people and what they don't know. However, if we look at it differently, one could also regard the rise in malpractice cases as a result of another paradox. Rising claims could be seen as an unintended product of this regime's success in touting the powers of science and urging people to see the doctor rather than the local or alternative healer. So without judging the correctness of patients' understandings of medicine at the time, we might interpret the conflicts between doctors and patients as part of the acculturation process that was underway. And with that, I will conclude and look forward to the conversation.
Thank you, Ken. Thank you very much. I enjoyed that very much, and I can see better where the project is going. I'm going to start taking questions, and I'll pass them along. So we're going to start with David Hoffman, whom we shall unmute. Sasha, are you unmuting David?
Yes, I just did. David, you can go ahead. Great.
Okay, thanks very much. Thanks, Yanni. Thanks, Ken. Excellent talk. Found it really interesting and had a couple quick questions for you. First, you mentioned that patients were dissatisfied with doctors' roles as state agents. And I could certainly see a case where, you know, there's some factory worker who wants to get off work, but they feel like the doctor's not giving them permission because they want to get them back to work and fulfill the plan. So certainly there's that tension there. I'm wondering from the doctor's side, if you saw any evidence that they were in fact thinking, you know, not so much of the patient's welfare, but were taking seriously these goals of, you know, meeting the broader good of fulfilling the plan. It occurs to me this goes back even farther than Soviet medicine. You know, if you go back to Zemstva physicians and so forth, this emphasis on social medicine. It's not exactly the same thing, but the sense that the good of the whole is important, perhaps even more so than any one individual. The other thing I was going to ask about was the show trial. It's really fascinating, that 1930s show trial of murderer doctors. You know, it of course made me immediately think of the doctor's plot, but if you're looking at the context of the time, this of course is much more in the vein of the Shakti trial, Industrial Party trial, you know, all of this specialist baiting that is going on. And I wondered if, in the same way that the engineers of the Shakti trial are being denounced as bourgeois engineers, are these doctors being denounced as bourgeois doctors? Is this very much a part of that that process?
Yeah, well, thanks, David. Thanks for the questions. Again, thanks for coming. I'll start with that. The association with doctors and specialists is definitely very evident in the sources and the discourse. I still need to read up on those trials more fully. They're talked about in Pravda and Izvestia. But what I have seen in some of the doctors' conversations about the violence committed against them is related to this idea of the doctor being seen as a specialist. I actually cut a small reference to it. There's an article called, it's called A Sick Person with a Revolver. This is from Bolnoy's Revolverum. in there, he talks about a patient who basically it's about the lack of trust on the part of patients with their doctors. And he begins with the anecdote of this guy. He's going in for an operation. He doesn't trust his doctor, so he brandishes this gun and makes his doctor promise that he's going to be carried out faithfully and do all these things. And in that article, the author brings it back to the problem of specialists, right? And that and the concern that people are not recognizing all the work and the hard work and the good work that doctors are doing to promote the revolution and to promote the public health, and instead are seeing them as this threatening individual of a different class background. So my guess is that the doctor's trial, obviously the one in Ukraine has overtones of nationalism and so forth, but that beneath there as well, it's I think the reference to the Shakti trial and experts and so forth is very good there. The other thing, of course, to remember too is that the medical profession is still living in the shadow of its supposed hostility to the revolution, right? That's still a kind of narrative that's out there that's promoted that doctors from the very beginning, right, or most of them were skeptical and had to be brought on board, and I think that's playing a role here too. Now, to your question about doctors and how they see their role here, that's a really great one. Like my sources, I don't think they can get at that right now. I guess where I've seen that, I referenced Mark Field's book, which I really enjoyed going back to, where he had the chance to interview doctors and patients there. And what he emphasizes about doctors is that they're troubled by this because they're being pressed both from above and below, right? That the factory managers, and there are accounts in the 1920s and 30s. And when I mentioned, I think that doctors are concerned about their bosses. They use this word periodically. Their bosses are the people, but also the authorities, right, who are interfering. So you do see some pushback about doctors being pressured by factory owners and others to either to put people back on or not. And what Field talks about is that, after a while, the doctors, when he's talking in the 1940s, they don't trust their patients because they don't know why they're really there, right? And then that I think has the effect of kind of undermining their own sense of dignity, right, as doctors and what they're there to do. But last thing I'll say, what he also says, so they end up then kind of playing a different role as a social worker, because they're trying to kind of smooth out the problems that the Soviet system has that they can't resolve, but they do then take on the role of trying to help patients navigate what we would say are non-medical issues, but are people issues, right? So there is examples of doctors who are willing to give certificates because it's a way of solving, right, of the obstacles of the Soviet system.
So if you have a question, please post it publicly or to me directly. So I have a list here of, in order, Fran Bernstein, Greta, and then Healy. Fran?
I mute myself. Ken, this was great, of course. I had a question first. I don't know if you mentioned where that Bolnoy with the revolver was published.
That was in Pravda.
It wasn't Pravda. Okay, so I was going to ask you about, so you have all of these internalist medical discussions of this, right? And then you have, the comparisons, the show trials. So I'm really interested in this sort of intermediate place where you would put something like Pravda or Izvestia, where, it's not show trials yet, but there already is another group with authority sort of smacking doctors down, right? And what I think might be interesting to look at, like all of the trials, the health trials, the sanitary enlightenment theater, right?
Yep.
Most of them are about, poor slobs and how terrible parents are and stuff. But there's at least one that is about a doctor. And I think it's about a doctor performing an unsanitary abortion. And this would be like 28-ish, 29-ish. And again, it's staged, although in principle the jury was the audience and they were supposed to adjudicate these things. But so there's that. And then also in the medical enlightenment stuff, you have all of these really interesting plays about either bourgeois doctors or Nazi doctors at the same time to talk about medical ethics. So they're not even talking about Soviet doctors, but of course they're talking about Soviet doctors, right?
Yeah.
So, and I have some citations for that if you don't have that stuff.
Yeah, well, great. I mean, those are great points. And I thought about the trials, when I've, like Elizabeth Wood's book, for example, there's some things in there that allude to this. The question of the press is really interesting because what I've been reading in the late 20s is, well, I guess if we went back to the doctors' diagnoses of what's the problem is, one of them is about the press, right? They're complaining that the press is sensationalizing these stories. They're publishing about a legal case before it's fully been investigated, and then that has a problem because it ruins the doctor's reputation. Even if the case is dismissed, it's already out there. So there's actually a series of articles in Pravda. I got to check if it's Izvestia as well, that are talking about the need to defend doctors, right? There's articles that we need to defend doctors and we need to recognize what they're doing. But there's a lot of calls in there for asking the press to stop sensationalizing, right? To stop kind of whipping up this fervor among the population. And I think what this always reminds us is that, especially in the 20s, but I think states are not they're not consistent, right? That there's different voices in different places speaking and saying often contradictory things. But it does show, as you say, there is an intermediate place where this is being set out, and I like the idea of also then the trials being as another place to get at that.
Greta?
Hi, Ken. That was a great paper. Thanks.
Okay,
Thanks for the organizers. Good to see everybody.
Could you give your last name by any chance?
Booker. Sorry, I don't know why it's not showing up. I don't know if you go this far into the 30s, but as I think you probably know, my work has also shown that in the post-war period that women saw doctors as agents of the police in the abortion.
What's that?
Sorry?
Yeah.
Oh, and I'm wondering if you see that in the post-36 period as well, in the pre-war period, if you see evidence that the doctors are feeling like they're being treated like agents of the secret police, or not secret police, but just the police, in prosecuting women for abortion.
Well, I haven't gotten that far ahead. I think this is really, I think you're bringing up a really great point about how they kind of navigate their roles there. So I can't really answer that question. But I think it gets at, again, the tensions that doctors are facing in terms of how they see themselves and how they are seen, right? And then that relates also to questions of power and authority, right? So in some cases, they do derive their power by their association with the state as a kind of state actor. But then what I'm also trying to get at here too is that this is coupled with a power that comes from their therapeutic powers, right? And how these maybe factor differently. When does one eclipse the other? I think it's probably at a level I can never get at. But I think if you project and even like looking at the post-Soviet world, a lot of what Rifkin, Fish, and others talk about is doctors trying to move away, lacking trust in the state, lacking trust in the authorities, in a way trying to kind of find authority in a way that keeps them separate from the state, which in their minds, is tarnished, right? So this is where I'm kind of getting off track here, but this is like where the unofficial payments come in as a way to avoid going through the state, right? And it's being seen in that sense as an ethical action as a result. But Greta, to your point, I think that's really interesting. I haven't seen that yet, and I would if I keep going, that's something I'd really like. I think I need to keep an eye out for.
Dan Healy, are you here?
He was.
Dan? Sasha, could we unmute?
Yeah, I've gone ahead and, oh, there we go.
There he is.
Thank you. Okay. Well, I really enjoyed this paper, Ken. Thank you very much.
Thank you.
I have a couple of questions or observations to throw out. I've been thinking a lot about embedded medical systems in the Soviet 1930s and 40s. And it seems to me, these are the systems run by the army, by the railway, by the navy, by the secret police. The Kremlin has its own medical service. In other words, a large part of medicine is not actually universal at all. It's actually quite specialized and privileged. And I think that must be very visible to the workers who are the patients you're talking about. That they know that if you go work for the Soviet railways, you're going to have your own specialist clinic. They know if they go and work for the Putilov Metal Works, there's probably a specialist clinic there. And those medical services often had higher doctor-patient ratios, more investment, and so on. And I just think that you can perhaps anticipate more resentment in some of your patients' complaints that comes from that, but probably unspeakable in the Soviet press. But I'm just finding that as medical historians looking at this from outside of Russia, we've been transfixed by the wonderful ideology of a universal medical system that's free at the point of use, right?
Right.
But in fact, that's not what the Soviets seem to have had in many respects. And so we kind of have to remember those other medical systems.
Right. And just to touch on that, what that gets me thinking about is that and how some of these tensions maybe are also not just with the medical system, but with other workers, right, and other individuals, right? So other patients, right?
Yeah. No, it's this hierarchy of consumption, isn't it? Some people have access to more privilege than others, I think. And another question for you is about, again, the trials of doctors in 1930 and then in 1938. Something not mentioned here is the fact that so many doctors are Jewish.
Yes.
And I'm wondering how much underlying anti-Semitism is there in the resentment, in the discussions, in the dramatization of these cases. Even just listing the names, as we know, would be enough for a Soviet readership to understand that these may not be, Russian workers or Ukrainian workers.
Right. Well, that's a great point, and I'll be honest in terms of how deeply I haven't gotten into them that deeply, nor have I really. And I think you're bringing something up, because of the other thing I think I need to keep in mind is also in some ways cataloging just the cases that are put into the press, right, and cataloging where they're taking place. Odessa, for example, seems to be a place where there's a lot of physical hostility towards doctors being expressed, and in some cases, I think there's Georgian doctors and others. So I think you're adding. I think what I'm hearing, and I really appreciate, is thinking about additional layers and nuance here, right? And I think part of that's going to depend on where I take this, right? I think what I found with with this topic is there's so many different ways to unravel medical ethics. There's a kind of more on the intellectual level and kind of how they're doing that, more at the doctor's identity level. And then what I've been trying to do here is kind of think more about the how this is playing out both at the intellectual but also the everyday level as much as I can. So I appreciate those correctives or those kind of calls for additional nuance, right, and to the story.
Great. But I think it's excellent.
We have, sorry. Go on, I'm sorry, Dan, go ahead.
No, I just wanted to say, finally, I think it's excellent work, and we really, really need this work.
Thanks.
We have a comment from Benjamin.
Hey, Ken.
Hey, Ben.
So this is just a comment that if you are able to take this up into the post-Stalin era, I was recently doing work on the early 60s and finding that sort of after the New Party program in 1961, there's this broad attempt to try to sort of bring back and realize the sort of the universal preventative model. And the key word here is dispensarization. And for my psychiatrist, the psychiatrist that I'm studying, I found that this went along with a pretty big change in their reporting duties. So that they're being put into every community, but they're also having to report on people who might be dangerous. And that really changes the way that they see themselves and the way that their patients see them. I don't know what goes on with other disciplines, sub-disciplines, but that's maybe a place to focus as you look at the evolution of the system.
Okay. Thanks, Ben. Yeah, I think what you're also getting at here, and which is reminding me too, and this also relates to Dan's point, is I didn't play it up much, but also the variation between urban and rural medicine, for example, and the the rural areas being very much underpopulated in terms of medical care. There's the perception that doctors there are less qualified, less experienced, which can result in certain problems there. But what you're also getting at, I think, here is this. This can go back to the question of the medical secret, but it's about the trust or how patients see their doctors and what the doctors will do with the information, right, that they tell them, right, and suggesting here that if they have these new reporting duties, I'm assuming that I don't know if you found that, but that would have then affected the way that patients and families might have seen doctors in terms of whether to turn to them, which ones, can you trust more than others? Raises, I think, questions about social networks, right? Are there doctors that one can see because of that they're more trustworthy than others because of that? The 50s and 60s, I will keep this in mind. Thanks.
Joanna Conterio has a question.
Yes, hi. Thanks for the talk. I really enjoyed this so much. And I was also really taken by the trials. I'd never heard about those trials, so interesting. So I have a question. First it's a comparative sort of medically question. And so it's a question about this dissatisfaction with changes in the patient-doctor relationship and how that's expressed. And you talk, of course, about these trials and doctors being sort of prosecuted, rather. And so in a comparative perspective, one really interesting way that I've seen in my reading this dissatisfaction being expressed is through the anti-vaccination campaigns, so especially in Central Europe, right? So there's a sense that with a vaccination, the sort of personal relationship with the doctor is destroyed, the discussions, the healing is gone, the healing influence of the doctor is gone. And instead, you just have this anonymous sort of vaccination process. And I've always wondered if there was much resistance to vaccination in the Soviet case. I mean, it was obligatory. So I've always wondered if this was a case where those questions of sort of duty to the collective and played out against the dissatisfaction with the changing relationship. If there is resistance to vaccination, that could be an interesting place to look. And that would also look what it looks like from the trials is that it's mostly having to do with surgery as opposed to with internal medicine, right? And so anti-vaccination campaign would be a way to look at sort of conflicts in that other area of medicine, right? And it also, I was wondering about that difference between the surgical and the internal, also because it maybe would suggest that there's sort of more of a consensus between the patients and the doctors and understandings of the causes of sort of disease and health in terms of the sort of fevers and also there's not as much of a raised expectation for therapeutics in internal medicine in the 20s and 30s as there might have been for surgery, where there might have been more conflict and disagreement and dissatisfaction between the doctors and the patients. So yeah, that's my sort of comparative internal question for.
Well, great. Thanks for those. The whole question of vaccination is really fast. I personally don't have an answer to that, like in terms of what, was there much anti-vaccination thought out there? But what I think you're touching on, which is really interesting, and I don't, again, have an answer to the Soviet case, but from a comparative standpoint, the argument for why surgery, for example, is targeted not just in the USSR, but in the US and Canada, is because it's seen as more mechanical. So surgery, the setting of bones, things like that, has a more mechanical aspect to it, or that's how it's at least sold and perceived. So therefore, it could be maybe, as you point out, that patients are maybe more likely to see it as a clear procedure, that it's mechanical, you do this is the outcome. And then when the outcome is different from what they expected, there's more dissatisfaction there, versus, as you point out, a lot of the therapeutic powers of medicine are really not going to come along until the 1920s, 30s, and 40s in terms of that. And there are all those vagaries of things like fevers. And indeed, part of what does come out is there's an underlying conversation here about how doctors treat each other, right? That's a whole nother aspect of medical ethics. And there's conversations there about doctors should not be airing their dirty laundry in front of their patients. And they should not be second guessing their colleagues in front of their patients, right? So, because to your point, doctors are arguing is that there are some conditions that are really hard to diagnose, right? The symptoms are kind of vague. So one doctor may see it as this, the other may see it as that. And there are some cases of patients kind of shopping around, right? We've seen that where they don't like the answer they got from one, they go to another doctor and they'll say like, that doctor ruined you, or that doctor. So they're also trying to, discipline doctors in terms of how they do that way. But I think this gets at my point. I mean, those of us who study Soviet medicine, one of the hardest things we've had getting at in terms of the history of medicine is the patient perspective, right? That side of the equation. And I think that's where it'd be really fascinating to kind of think about, these perceptions of one's body, right? And what does health mean? What does it mean to be productive? So if I, there's also a lot of evidence again in the West about the improper setting of bones causing more and more medical malpractice cases because a person can't function the same way, and arguing that people had a different notion of the healthy body or the proper body or the productive body. And And so there are all these really fascinating layers here. I don't think I'm going to get to them. I think, but it raises that really important question and the value of trying to tease out, right, these kind of cultural dimensions, the popular dimensions of these of the relationships here we're talking about.
Ken, you have a question from Susan. Susan, your last name, please, if you don't mind.
Sure, Grant, Susan Grant.
Hi, Susan.
You're welcome. Hi, Ken. I really liked how you're bringing out the tension between theory and practice when you're talking about doctors. And I wonder if you could just talk a little bit more about the intellectual aspects of ethics, and I guess in particular the development of a code of ethics. So I'm not sure how it is for doctors in the Soviet Union, but I know for nursing, this just doesn't really come about until the 1950s. I'm just wondering what are the kind of standards around ethics and the development of the code in terms of, sort of publications, curricula, and medical institutions, and so on. So if you could just talk a bit more about that.
Sure, I'd love to. Thanks for that question. Doctors before the revolution did take a kind of oath. There was a doctor's oath that was dropped after the revolution, and they don't get a new oath until I think 1971, the oath of the Soviet doctor. So for 60 years, there is no formal code. And in some ways, this is, the whole debate about whether ethics should or should not be codified is not one unique to the Soviets. There's you look at the medical profession elsewhere. Here in the United States, one of the first big codes was the AMA code in 1847, and then that led to what became known as the no coders, who argued against the imposition, right, of codes of ethics as kind of a violation of autonomy. And of course, that was very much rooted in notions of honor, right? The doctor was, a lot of early medical ethics are built on this notion of the gentleman, physician, and honor. So obviously one of the challenges in the Soviet period is what's the foundation, right, upon which we develop an ethical code. They look in some respects to the past. So, David mentioned the Zemstva doctors, and there's Veresayev. So there are examples of kind of the selfless doctor, the social activists and so forth that they call upon, but they still can't fully call upon the past. So I would say like the broad theoretical default that eventually emerges, whether or not everybody accepts this, is that doctors should not have their own special ethics, that medical ethics as a special set of ethics that only apply to this one group of people in Soviet society are not valid, because doctors are Soviet citizens, and therefore they should be guided by this broader set of ethics with some things as necessary. There's also the general belief that this is a broader kind of belief that's being put out there, that anything that promotes socialism or promotes the working class is ethical, right? That's another thing there. So there's a lot of resistance to the idea of codes, right? And I think it's because it echoes the idea that the code reflects the idea of doctors as this special autonomous body with its own rules and regulations that only it can fathom and it can be in control of. So I think there's that there. One side thing is I have done some work about conversations about communist ethics in the 20s, which is a whole nother kind of overlay here. And even there in the Communist Party, there's a debate about whether they need a code. Especially young people they're all confused, right? Like what does it mean to be ethical? What does it mean? What are proletarian values? What are communist ethics? And there are some Komsomol groups and others who are writing to Yaroslavsky, for example, and saying, we want a code, like tell us how to behave. and he rejects it, right? They reject this idea. So I think it's partly because there's no consensus, but it also, the code, again, it kind of reeks of what they would call bourgeois medicine and so forth. And I think I haven't gotten into really why it comes back in 71, and maybe you could tell us your thoughts about why the nurses get it in the 50s, but I suspect it has something to do with kind of changing notions under professionalism at that time.
Yeah, it's, I mean, theoretically, we're at the end here. I must be dreaming. It's going on 1:30. No, this has been a wonderful discussion. Ken, would you mind if I pose one last question? In the context of Soviet power, but the advantage of posing it as a professional question is that you see certain things, an ethical question, a relationship to power, authority, conduct, codes of ethics, and it has a potential to obscure other things, which is not necessarily a bad thing, because we tend to overemphasize certain things when we talk about the Soviet period in the 1920s. One of them is class, right? And the other one is change over time. So with that in mind, I was going to ask you if you see any opportunity as you advance in your project. And here it's more just an opportunity. It's not a necessity at all for your project to work. But I do have the sense of there's a class subtext to this, as there is to everything in life, right? And I wonder if it's worth talking about or bringing out. I get the sense that the complaints are coming from certain socioeconomic strata and not others, but I'm not sure. There may not even be a pattern, right, which would itself be worth commenting on. But it was brought to my attention recently. Last week, we were presented a chapter here at NYU from a dissertation student, Marek Eby, who I think is here now, who's running malaria. And he pointed out that class isn't simply a matter of preference and about policy, but class is also a matter of legibility, meaning who is easily reached, who is easily understood, who is legible, who's vocal, who can fill out a form, who's literate. And this produced certain class biases in medical policy, in this case, malaria. Marek, if you're here, and if I'm misquoting you in some way, let me know, or misrepresenting you. And so I wonder if it comes out in any of these ways, right? Probably less the voluntary decision to have a class bias and more who's likely to be seen and who's likely to participate in, for example, malpractice complaints. And that's one of them. Now, against that would be what you're presenting here, I think, which I think is fair and also consistent with your earlier work. What you seem to be presenting here is the social rather than the class, meaning you have an aggregate of people who are all biological entities, all of whom have certain kind of medical conditions, all of them have the right to treatment. And the social is something which does not necessarily allow or encourage a distinction into different socioeconomic categories. It can, obviously. But the way you're presenting it, I thought you were presenting it more as a social body encountering a medical professional and Soviet power, which is different from class, obviously, or their intention with each other. So this is more just, a thought. You don't even have to answer now, unless you want to, but it's a thought you might want to put away. The one that I had a more immediate concern, which I think has been raised already by David onward, which is change over time. And even though it's the 1920s, it still allows for change over time, I think.
Right.
And I had the same reaction as others did, which was, if I see a show trial in 1930, I know that I'm in Stalinism, right? And it's not the same thing as 1921. It's not the same thing as 1924. So I wonder if some of these things will require some context and texture, following some sense of historical change.
Okay. Yeah, I think, let me just sit here for a second. To your first two questions, I think I'm gonna sit with those. And in terms of the class subtext, so part of the problem, or one of the challenges, is really kind of the patients that I'm getting are refracted through the lens of the doctors, and so it's a question of how they are representing this group, and so it's going to be how they are interpreting class. But there is a definite class dimension in the sense that they are facing, I've used the word consumers in a way, not in the way that we would think about it, but that the that the Soviet regime is, at least on some level through social insurance, for example, is promoting the idea of a kind of patient consumer who has rights and in some ways also the responsibility to make claims on doctors. And let's see, I had a bunch of quotes here that at some point I had put aside. Maybe I'll end with my quote about how Stalin's like the ultimate model for doctors. But let's see. Yeah, so there's this kind of idea that the people have a kind of right to demand a certain kind of care, to participate in it. And so there is this kind of class subtext, I think, that not only are they facing a kind of activist patient, for lack of a better word, but the patient is coming from a different social world than them, or is imbued in their minds with a particular set of attributes that they are dealing with. But I have to think more about the class and social part, and then let's talk. To your point about change over time, I totally agree. I think that what I'd like to show, I think, again, if I do take this over time, the question is how fine-grained I can get it and want to get it, because then that's sometimes where you get bogged down. But I would like to kind of get at how different concepts and ideas do change, even in this context there, in the same way that we also have to be careful about how words and terms that they're using at that time mean certain things to us, and we have to be careful about how we're interpreting that, something again like patient autonomy. So I'm going to that's kind of a punting of these questions, Yanni, but I think it gives us a reason to get together for a beer over Zoom at some other point.
We'll form our own bubble, Ken.
Yes.
Anyone else like to make a comment? I see a parting comment from one of the comrades who says we should do this more often. I agree completely. If anyone is here who would like to give a paper in the near future, or even in the more distant future, would like to share some work in progress, it could be a text or it could be a lecture, by all means, get in touch. It's one of the more vibrant fields. It takes us in unexpected directions, as did Ken today. If there's nothing else, I'd like to thank everybody for being here.